Hello, this is Marie Roguski, and I'm going to be talking to you today about adult tethered cord syndrome. This talk will have several objectives. First, to discuss the definition and epidemiology of adult tethered cord syndrome, to review the pathophysiology of why symptoms can occur in adulthood, discuss various common etiologies underlying the development of this syndrome, and lastly, to review treatment options of adult tethered cord syndrome. As an introduction, occult spinal dysgraphism, OSD, refers to a collection of congenital anomalies of the lumbosacral spine, which are largely due to malformation of midline dorsal, neural, mesenchymal, and cutaneous ectodermal structures during very early embryogenesis. Specific pathologies that are seen include lipomyelomeningocele, split cord malformations, terminal syrinx, neuroenteric cysts, fatty filum terminale, meningocele mencae, and dermal sinus tracts. Neurological deficits are often progressive and are related to caudal traction from tethering by OSD. And due to this, many neurosurgeons advocate for early operative detethering to prevent further development and to inhibit progression of neurological signs. The true incidence is difficult to estimate. Often, individuals with occult disorders remain undiagnosed, and the diagnosis is only made when the individual becomes symptomatic. However, on MRI series, the incidence of filum terminale lipomas ranged from 0.24% to 4% in MRI series. However, this has been seen to be as high as 4 to 6% in some cadaveric series. Overall, tethered cord syndrome is largely considered to be a pediatric disease. And previous studies have based tethered cord syndrome on the timing of presentation, as well as the presence of dysgraphism. However, review of the nationwide inpatient sample, NIS, by Ladd et al., revealed that of over 8,000 patients with tethered cord syndrome who underwent surgery between 1993 and 2002 in the United States, nearly 30%, or one-third, were aged 18 years or older. This reinforces that this is not solely a disease of the pediatric population, but can be seen in adults. Pang and Wilberger described two overall patient populations of tethered cord syndrome. First were children who were healthy in childhood, but then developed symptoms later in life. And the second population are patients with a previous diagnosis and stable deficits from childhood that then developed new or progressive deficits in adulthood. McClone expanded this into three categories: patients who were previously asymptomatic, who then developed ongoing cutaneous signs and symptoms, an occult group without cutaneous symptoms, and then lastly, a previous diagnosis of spinal dysgraphism with or without a prior detethering procedure. Regarding the pathophysiology, although lesions are present congenitally, symptoms may develop or worsen over time due to ongoing cord traction. Yamada et al. Describe several factors that contributed to symptom development, and these include increasing fibrosis of the filum, which leads to a loss of viscoelasticity, a growth spurt that causes a rapid increase in cord tension, an increase in physical activity leading to a more repetitive motion. Of note, the length of the spinal canal does change as much as 7% during flexion, and thus flexion can be considered to occasionally precipitate symptoms. Development of spinal stenosis that can restrict movement and may accentuate tension on the spinal cord. Overall, pathologic stretching of the spinal cord has been shown to be associated with metabolic derangements similar to those seen under ischemic conditions. These changes may be mediated by physical neuronal damage due to tethering, impairment of oxidative metabolism, and reduction in blood flow to the spinal cord during flexion movements. Although damage due to severe stretch may be irreversible, mild or moderate damage may be reversed by cessation of the pathological spinal cord stretch following a detethering procedure. Overall, patients with tethered cord syndrome typically present with pain, motor or sensory deficits, and sphincter disturbances. Pain is typically described as non-dermatomal, shock-like, or burning in nature. It's insidious, but may have acute onset or aggravation with relation to activity or an insult. Motor or sensory deficits are also generally progressive and insidious in nature. They typically start distally or with worsening of known deficits. Lastly, sphincter disturbance can be seen, and these are often urinary symptoms such as urinary urge, incontinence, and frequency. Occasionally, patients can present acutely. This may sometimes develop following acute trauma to the lumbar spine that may aggravate or exacerbate the loss of mobility of the spinal cord. Changes to ligamentous laxity during pregnancy may also be associated with the development of symptoms. Lastly, disc herniations or progressive spinal stenosis may also contribute. The overall treatment strategies of adult tethered cord syndrome are multiple. First, the natural history of adult tethered cord syndrome is unknown and controversial. Generally, treatment is extrapolated from the pediatric data. However, this is an extrapolation and may not represent the same patient population. Timing of neurosurgical release is controversial, as it is difficult to predict if and when there will be deterioration in that particular patient. Once deterioration is seen, surgical intervention is typically recommended. Overall, when there is clinical suspicion for occult spinal dysraphism in adults, an MRI without contrast is recommended. If the patient is asymptomatic and has a dermal sinus tract with risk of meningitis, the patient undergoes baseline urinary dynamic studies, and then surgery through intradural detethering is recommended. For all other etiologies, baseline urodynamic studies are recommended, followed by clinical surveillance and periodic urological monitoring. A repeat imaging study is recommended if symptoms progress. If new neurological symptoms or symptomatic progression occurs, surgery is recommended at that time. If a patient with OSD on MRI is symptomatic, surgery is recommended. Following surgery, if symptoms recur or there is a new neurological decline, an updated urodynamic study is recommended. An MRI without contrast with consideration of prone or dynamic imaging is recommended. And lastly, if retethering is considered to be the etiology of the worsening, revision intradural untethering or spinal shortening procedure can be considered. This time we'll go over some particular etiologies of adult tethered cord syndrome. The first one that we will talk about is a thickened and fatty filum terminale. We will then talk about meningocele Menkei, dermal sinus tracts, as well as other etiologies such as split cord malformation, myelomeningocele, lipomyelomeningocele, and arachnoid cyst. These two MRIs demonstrate examples of lipomyelomeningocele as well as an intradural lipoma. The T1 images demonstrate bright fat within the intradural space. So fatty or thickened filum terminale is essentially a viscoelastic band that enables the spinal cord to accommodate changes in spinal canal length without neuronal stretch. When there is change in the structural elements of the filum terminale, this may result in an inappropriately tense filum that prevents normal stretching of the spinal cord with flexion and extension of the spinal column. This may be seen in up to 6% of the normal population, and the vast majority will not develop symptoms. This figure, in particular panel A and panel B, are sagittal and axial T1 MRIs, which demonstrate a region of T1 hyperintensity or bright fat within the filum terminale. Some authors advocate for the use of prone MRI to identify the posterior location of the tethering phylum. Sensitivity of prone MR imaging has been reported to be as low as 62%, and thus this limits the utility of this imaging modality. Dynamic MRI imaging also suffers from low reported sensitivities as well. Despite this, these modalities may provide additional information that, when taken in the correct context, may provide useful clues to a clinician regarding diagnosis and appropriate treatment strategies. Patients with a low-lying conus medullaris and a fatty phylum should undergo surgical detethering to prevent clinical deterioration. Detethering is usually performed through an L5-S1 laminotomy, remote from the cauda equina and termination of the spinal cord. Once the phylum terminality is identified, electrocautery is performed in order to transect the phylum. Meningocele manqué is named for the French word manqué for having failed to become what one might have been. This is fibrotic or atretic neural tissue that is instantly discovered during surgical exploration. This typically extends from the dorsal aspect of the spinal cord or nerve roots to the dorsal dura. This may sometimes extend up to the lamina or through the laminar defect. This can be associated with other dystrophic states such as Syringomyelia or split cord malformation, dermoid cyst, neuroenteric cyst, or abnormal bony or fibrous midline septa. Bands can exist at some distance from the site of clinical tethering. Failure to appreciate these bands may lead to inadequate detethering, and persistence or worsening of tethered cord syndrome over time. Most often, these are found in the lumbar and thoracolumbar regions, but approximately 15% may be located in the thoracic and cervical spine. They are localized to a single vertebral level in 21%, to 2 vertebral levels in 42%, and can span 3 to 5 levels in 21%. The diagnosis may be challenging, although this can be seen on CT myelography as a thick linear filling defect extending from the spinal cord or hemicord in cases of split cord deformity to the dorsal dura. MRI may show a small, thin, linear structure with intensity similar to a spinal cord on axial T1 weighted MRI images. The sensitivity of imaging may be as low as 55%. When there is concern for clinical tethering, surgical ligation of these bands is indicated. Dermal sinus tracts are an abnormal stratified squamous epithelium-lined tract that connects the skin and soft tissues of the back, thecal sac, and neural elements. Up to 60% of all dermal sinuses reach the subauricular space, with 25% contacting neural elements. These may present clinically with variable findings, but if there is an open communication between the skin and nervous system, meningitis, epidural and subdural spinal abscess, and intramedullary abscess have been reported. Dermal sinus tracts are best diagnosed on MRI imaging. In this MRI, a clear tract is noted from the skin of the lumbar region extending to the lower lumbar spine. On T1 weighted MRI imaging, this appears as a rostrally or caudally coursing linear, curvilinear, or cone-shaped area of hypointensity within the T1 bright subcutaneous fat. Intradural portions of the dermal tract may be better visualized on T2 weighted imaging due to a greater contrast with CSF. Other findings that may suggest the presence of a dermal sinus tract are tenting of the posterior dura as the fistula enters the thecal sac, clumping of the nerve roots due to rhabdomyolysis from previous infection, and presence of inclusion cysts. Due to the significant morbidity associated with central nervous system infections, many authors have recommended prophylactic resection of the dermal sinus tracts. Although these may appear innocuous, treatment requires complete excision of the tract to prevent complications such as infection, inclusion tumor, or recurrent tethered cord syndrome. Exploration of the dura and intradural plane is essential to prevent inadequate removal of epithelium-producing cells and inclusion cysts. Lastly, regarding treatment, although the benefit of early surgery is well established for patients and pediatric patients with tethered cord syndrome, the timing of intervention in adult patients is controversial as the natural history of this disorder is unclear. Some authors have estimated that over 50% with clinical symptoms and signs of TCS will develop neurological deterioration over time, but others have reported a lower rate of progression. One study of the natural history of 85 adult patients with tethered cord syndrome, with approximately 50% treated with surgery and 50% treated conservatively, demonstrated that the clinical recurrence rate of symptoms among conservatively treated patients was about 21% over 10 years, about 1 in 5. The majority of conservatively treated patients remained neurologically stable at follow-up. The recurrence rate was 47% within 5 years in the subset of patients who refused an initial recommendation of surgery. In contrast, 81 to 89% of patients undergoing surgery remained neurologically stable or improved, and surgery-related complications occurred in 16% of operations performed. The primary surgical goal, regardless of etiology, is complete untethering of the spinal cord. This can range from a simple transection of the filum terminale to more extensive operations for complex malformations. Prevention of recurrent tethering is an important goal of the initial surgery, as recurrent tethering can occur in 5 to 50% of patients. Surgery for recurrent tethered cord syndrome is generally more difficult than initial detethering procedures due to the presence of arachnoid adhesions and scarring. The results are often suboptimal, and there is an increased risk of perioperative complications such as spinal fluid leak, pseudomeningocele, neurological deficit, poor wound healing, and retethering. Given the surgical limitations for recurrent tethered cord, one option that has emerged potentially remove the stretch of the spinal cord, a spinal column shortening. Grand et al. Developed a cadaveric model to evaluate the effect of vertebral column subtraction osteotomy, VCSO, or spinal shortening, on the tension of the spinal cord, cauda equina, and filum terminale. Their results indicated that a 15 to 25 millimeter osteotomy produces excellent relief of tension, and that release of greater than 90% of neural elements would be required in a traditional detethering procedure to replicate the effect. Subsequent series have replicated promising results that are in line with traditional detethering techniques.